I'm Gifford Batstone. I'm a chemical pathologist. I do my chemical pathology practice in Brighton, where I work a bit in the lab, but concentrate more on making sure that the medical students in Brighton know more chemical pathology and metabolic medicine than any other medical school. And 2 days a week I work for the National Pathology Programme in London. Well, IT's been important in pathology for a long time because it's the way in which we transmit stuff to GPs and has been now for over 10 years. It's the way we're increasingly getting information from GPs in terms of requests and the clinical data supporting those requests. And really we're just into this phase of expanding that and learning how to link more efficiently the clinical information in order that we do the right test for the right reason to the right person at the right time and get the result back to the right person who then takes the right action. And we've got to see pathology, I think, in that entire bit. It's not just from when the sample comes into the lab to when we actually sign off a report. It's increasingly about what's called the brain-to-brain cycle. How do we actually help the thinking of the clinician about doing some tests right through what the clinician then does with those results. So that concept of the brain-to-brain cycle, rather than just being a sort of box called a laboratory with samples coming in one end and reports going out the other, I think that's the transition that IT will enable. I think we've got different audiences here and we've got different messages for them. For the pathology community, I think we've got messages going saying people want to use pathology data for all sorts of purposes, and if we don't standardise it, they're not going to use it as well as otherwise. And that's about naming and coding and units and all the boring stuff, but actually is the base stuff for all of this. The second audience I think we need for pathology is to think about is the patient, because increasingly patients are going to see this data and they're going to ask questions to this data, which I think pathology could find slightly embarrassing. And my estimate is we've got somewhere about 18 months to sort out a whole lot of variations in methods, a whole lot of variations in how we do things, in order that we have a much more standardised, transparent system, evidence-based, that we can explain to patients what's going on. And that's, to my mind, is the trigger. From that, I think, then comes a whole lot of pressure on organisations, like professional organisations, the in vitro diagnostics producers, the IT people, to say, this is what patients are demanding, how are you going to get there, guys? All right, 3 key challenges. The first one is, if we put aside the methodological variations that pathology has to deal with, then it's about how do we make sure we get total standardisation of the way we report stuff so that it has exactly the same meaning anywhere somebody looks at it. That's got to be the first key one. The second one, I think, is going to be around how we use big data. So, in Brighton, we recently took from Rick's survey over 1 million albumins. We have to show an age and sex variation. That's not been reported before. So what other data is there within that big data that we could trawl in that way to actually get a better understanding of how methods are changing, what the difference are between methods, what reference ranges we should be using for age, sex. Pity we don't gather stuff on ethnicity, because that's a big important thing in our global society is what are those reference ranges. So that's the second bit. And the third bit, I think, is how pathology adapts its reporting in order that patients can understand what's being said. And I think there's a whole new art or way of thinking about how do we report for patients rather than for other dogs. I think there's an issue about how we take this forward. And what we don't want is for there to be some great program at the centre that churns over this and tries to make it perfect. If we can get 70% of it right, then that will deal with 97% of clinical situations. And Andy, this morning when he was talking about the derivative stuff, we can cope with 70% of the big stuff, but some derivatives are so rare we still go back to paper. And what we don't want to do is the bits that go back to paper can stay on paper for the NHS as well. What we don't want is to try and make it perfect for every single occasion, because it won't be. And all they'll have to do is we'll get bogged down. Got to keep it simple, straightforward, focused on the patient, do as much as we can.